So I will challenge you now a little bit. I mean, craniopharyngioma is a pediatric brain tumor, and so far we heard nothing about the oncologist. And that's a little bit weird. Or maybe also that means craniopharyngioma is a little bit behind. We had this development in all pediatric brain tumors. It was first always the domain of surgery, then there comes the radiation therapy, and then from time to time with also that chemotherapy can work, and with this the pediatric and especially the neuro-oncologist was coming in. So I will try to convince you a little bit in the next 15 minutes. Maybe there is something else. We need surgery, we need radiation therapy, but there's maybe also something else we can offer these children. And I'm starting maybe with our first encounter. I mean, we were in a lot of clinics already responsible for these patients regarding all it's a chronic disease for the long-term follow-up. But what could we offer then? And Shlomi introduced this a little bit, but I'm coming back to this. Like really for cystic craniopharyngioma, intralesional therapy. That looked like as an easy thing to go. We used different things before, and in the last years, really interferon alpha was coming up, especially to the point if you have a leakage in the cyst and it goes into your normal brain tissue, that you don't harm the cyst. And this paper was really, before you had only like single institutional series, so relatively small numbers. And it was a multi-center assessment on behalf of SIOP-E, so that's the European branch of SIOP, as well as ISPN. And it was like more or less a fixed schedule that was proposed from the Toronto protocol. So intron A as intracystic, you see the volume, so 3 million units, which corresponds to a volume of 1 milliliter for 4 weeks, and like 3 times like really a week. Most clinics did it, the Omaya is clear, then you will really check that there is no leakage, which you did like with contrast before to thesis. Problem is, I mean, as the course is going on, you could still get a leakage over time, and then like really inject this via the Omaya. And what you can see here, they were able to have 56 patients from multiple institutions. That's the downside. You can really see here median age, follow-up, sex, ethnicity. As we expect, like 2/3 were the typical childhood craniopharyngioma. Unfortunately, for 1/3, we don't know. Not like so much cystic predominant, as you can see here, only up to 40%, 60% were like really mixed. And overall survival was 91%. So already demonstrating that this is really a chronic disease. But looking at this curve, looks not really promising. What have we really achieved with giving this interferon? We can say maybe we had to delay further treatment for quite some time, but not very long, maybe so up to like a year. On the other hand, most of the kids like really had no severe side effects with the therapy. So maybe there's still room for that. But as you can see here, look at the progression, and then they got like tons of therapy before and tons of therapy like really after, everything, even sometimes like re-challenge of interferon. But at the end, that was not as good as we all hoped it would be. But maybe let's look a little bit at the symptoms. Can we get something like from this? Red is deteriorated, green is improved, and blue is stable or no comment. Like even this does not look really promising. So interferon didn't really do the trick. So we had to go back, and that's always like go maybe back to the benches. And as you know, all the data on other pediatric brain tumors on like really pathways and all the molecular results have exploded over the last decade. But like craniopharyngioma was a little bit behind. It was first maybe not so sexy, not so popular. It's also hard. It's like a really slow growing tumor. Do this in the lab. But now in the meantime, we have like some really strong research groups, and we got some like really interesting data. And we found some potential targets for treatment. And there you can see there are some of the usual suspects, which we now have quite some experience with in like pediatric neuro-oncology. It's the MAP-ERK pathway, which is very prominent, as you all know, in low-grade glioma in children, where we have now quite some experience. Wind signaling pathway sounds also really familiar to you, because that's what we know from medulloblastoma. Inflammatory pathways, not so much. That's something maybe more like for craniopharyngioma, and then like the programmed cell death pathway. What does this help us? The pathway is only as good as it is. If you don't have treatment for this or like any targets, then it doesn't really help to know the pathway. Thankfully, there was quite some development in this. So we have now quite some pro-inflammatory mediators. So blockage, for example, for interleukin-6, there are drugs available, tocilizumab or ciltuximab. That's something coming from rheumatology for rheumatoid arthritis, or like even other antagonists. Nivolumab and pembrolizumab for PD-1 inhibitors. We have tons of inhibitions for the MAP and ERK pathway. There, you know, it's exploding, and more or less each pharmaceutical company is coming up with their own inhibitor. And also, like, something which is like really interesting is this concept of senescence-associated secretory phenotype, something which we are now also developing for low-grade glioma outside of the MERK-ERK pathway. And I want to show you here like some trials. They are all either upcoming or ongoing, so I can't present you any results. We've heard before craniopharyngioma is a rare disease, and you have seen from Herman like how many are treating this. So in these trials, it's like really on selected centers. So all of these trials I will demonstrate you are only in selected centers. They are available in Europe, but none of these trials will really open in Switzerland, we have to say. So if we have like children which are eligible for any of these trials, they have to go abroad. One of the first trials is at the Children's Hospital in Colorado with tocilizumab, and they are really also measuring if they get like really drug levels at inhibitory levels, and they do this like in the cyst fluid and tumor tissue, so in both. And then if they are really able to measure this, they will start a trial with a standard protocol up to 1 year of treatment and then see if this is changing something. That's just only a single center trial. Then there are 2 trials within the CONNECT consortium. That's a transatlantic consortium, so also with centers in the US, with tocilizumab. The dose was just like adapted from rheumatoid arthritis. So there is a lot of like data out. So that's what we're doing. This should be opened anytime soon. And as you can see here, we have 3 centers open within Europe. So it would be Gosh in London, Princess Maxima in Utrecht, and Heidelberg in Germany, where we could like really get our patients in. CONNECT is in parallel also starting a second trial with a MEK inhibitor, because there was some data that MEK inhibition is helping in a patient with the Wind-activated craniopharyngioma. It's this type, the MEK inhibitor from Pfizer, with a dose of 32 milligram per square meter BID. That should be opened within the year, maybe in Q3 or Q4. And then there is, I think, a very interesting trial from PNOC, which is the Pacific Pediatric Neuro-Oncology Consortium, which is has not only participating sites around the Pacific, but also within Europe. So Princess Maxima Center in Utrecht, as well, for example, Zurich, are both members now of this consortium, and they try to do a combination of nivolumab, which is a PD-1 inhibitor, and DAY101, which is maybe, at least if you believe the company, one of the most promising pan-RAF inhibitors, because it has a really good CNS penetration and you only have to give it weekly orally. Would be an upfront trial, and endpoints, I think, really important, not only progression-free survival, but also quality of life. But one of the issues, which I think we have to be careful from the beginning already, is the pseudoprogression, because we know that this like pathway inhibition can increase inflammation. So we will potentially get a lot of like issues and like really try to interpret then the MRI findings. Is there a downside to this? If we extrapolate now the available data we have, especially on the MAP-ARC pathway inhibition from low-grade glioma, I would say yes, because we were all extremely enthusiastic that we have now targeted treatment for low-grade glioma, and we have just been all at the ISPNO where the first results was shown. They respond, most of them, beautifully, and a response we would have never seen with chemotherapy. But it's a targeted therapy, and at some point you have to stop these treatments. And unfortunately, most of all are showing further progression. So if you're like really looking at the progression-free survival following stopping this treatment, it's not better at all than our conventional chemotherapy. And this at the end is really disappointing. And plus, I mean, low-grade glioma is also an example for a chronic disease. The toxicity is way higher than on our conventional chemotherapy. And it's, for example, mainly skin toxicity, which is like really a big issue for the patient and really like decreases their quality of survival. So I think we have like now already like some knowledge, and I think have to keep this in mind, even if we are all eager to try this out. But I think it will take quite some time for craniopharyngioma. When is the right time point? How long should we treat? And what is happening as soon as we're stopping all this targeted treatment? And with this, I thank you for your attention and happy to answer any questions.
Thank you for being perfectly in time. You have questions?
Just a comment, I think because it is such a rare situation, also it's not a great impetus for the companies to invest money in a study which would take such a long time and so difficult to evaluate the results on chronic disease. Doesn't leave a lot of place for optimism in this one.
I absolutely agree. I mean, the only company who's investing a lot at the moment is Day 101 because they want to get this license. But I think the others will lose interest soon if it's not proven to be successful. Absolutely.
How do you see the integration of these new treatments? They are active in the context of the other treatments like surgery or proton therapy. Do you think it's more in a neoadjuvant setting or in adjuvant patients with relapse?
I think that's really tricky because, I mean, I think we have to look at the both endpoints, progression-free survival as well as quality of life. And especially, I think the quality of life in a chronic disease is really important. So I'm not sure if they will come to upfront or if they will not replace at least limited surgery, and whether they are really a good alternative to radiation therapy, I think it's too early to say. Maybe we know a little bit more in at least 2 or 3 years if the first trial have run for quite some time.
The other thing I just want to comment with interferon.
Yeah.
There's always, when there's a new treatment, first there is enthusiasm. It's being reported from one center and it's making a miracle. But once you put it under, a study, or even if it's not a perfect study, you realize that it's not that great. That's also sad.
Absolutely. And I think, we were so enthusiastic, but you see, there's no prospective trial. I mean, there was a lot of discussion about this, but no one really managed to start a prospective trial on this with the first, really results. Good.
Okay, thank you.